Hi everyone, welcome to my lesson on pancreatitis. We're going to differentiate between acute and chronic pancreatitis, use the nursing process to treat a patient with acute pancreatitis, and discuss complications. The pancreas is a gland that is right behind our stomach. The head of the pancreas is connected to the duodenum, which is the first section of the intestine after the stomach. You can see that the common bile duct of the gallbladder goes through the head of the pancreas and merges with the pancreatic duct. Where they merge is called the sphincter of Oddi, and where they attach to the duodenum is called the ampulla of Vater. This connection is where bile is released into the intestines from the gallbladder and where pancreatic enzymes are released from the pancreas. The pancreas functions as an endocrine gland and an exocrine gland. The exocrine cells produce digestive enzymes like amylase, lipase, and protease, which travel through the pancreatic ducts into the duodenum where they are activated and able to digest proteins, carbs, and fats that we eat. Endocrine cells of the pancreas are located in the islets of Langerhans, which are spread throughout the pancreas. These cells are responsible for releasing hormones like insulin and glucogon straight into the bloodstream to regulate our blood glucose levels. When the pancreas experiences trauma, whether from surgery or alcoholism, or the ducts are obstructed like in the diagram to the right, it may lead to pancreatitis. The pancreatic enzymes are unable to exit the pancreas, leading to digestion of the pancreas itself. Autodigestion of the pancreas by its own enzymes leads to four major consequences. The enzyme lipase that normally breaks down fat into fatty acids causes fat necrosis by breaking down fat of the pancreatic cells. This is called lipolysis and results in fatty acids that combine with calcium, leading to hypocalcemia in the body and fat necrosis of the pancreas. Proteolysis is the breakdown of proteins in the pancreas. One enzyme responsible for this is trypsin. Protein breakdown can occur in one section or throughout the pancreas, but it causes death of pancreatic tissue. Trypsin also activates elastase that eventually dissolves pancreatic ducts and blood vessels. Necrosis of blood vessels can cause minor bleeding to severe hemorrhage. The hemorrhage can be worsened by another enzyme called kallikrein, which leads to vasodilation. The hemorrhage can spread into the abdominal cavity, and this can lead to shock and death. With all of this necrosis going on, this triggers the inflammatory process to kick in. And these main processes make up pancreatitis, and we will talk about the complications that can occur in a later slide. There are two types of pancreatitis. Acute pancreatitis is temporary and you can recover completely from it or develop chronic pancreatitis. Chronic pancreatitis is progressive, irreversible, and it is usually a gradual destruction with periods of remission and flare-ups. There is chronic calcified pancreatitis, which is primarily caused by alcoholism, where the secretions of the pancreas develop plugs that block pancreatic ducts and cause fibrosis and calcification. The pancreas ends up becoming very hard and unable to function. Chronic obstructive pancreatitis develops when the sphincter of Oddi is inflamed or obstructed, usually due to gallstones. Like acute pancreatitis, you have backwards flow of the pancreatic enzymes and autodigestion. Now, the majority of the time, the cause of pancreatitis is actually unknown, but acute pancreatitis can be caused by trauma to the pancreas from a surgical procedure. A common cause is gallstones. Alcoholism and some other metabolic disturbances can also contribute to pancreatitis. Our patient's name is Turner. She is a 53-year-old female who came to the emergency room with severe boring pain, 10 out of 10, in the mid-epigastric area radiating all the way to her back. She's laying on the stretcher in fetal position, and she has thrown up 4 times since dinner last night. For her pain, the doctor orders IV morphine every 4 hours as needed. She is not allowed to eat or drink anything, and we are giving her IV fluids to keep her hydrated. Once her pain is under control, she goes for a CT scan that shows an enlarged pancreas with a small fluid collection, and her ultrasound shows gallstones at the sphincter of Oddi. Labs were collected. You can see her vital signs. It looks like she's had an endoscopic retrograde cholangiopancreatography or ERCP done for gallstones about 10 years ago. This is when a scope is sent down the throat all the way to the duodenum. A small cannula is released and an incision is made at the sphincter of Oddi, and the gallstones are removed. To get rid of the gallstones, she has been scheduled for another ERCP, but let's do an assessment and check out her labs while we're waiting waiting for transport to arrive. Okay, she looks a little jaundiced. This makes sense because the gallstones are in the sphincter of Oddi, blocking bile. She still has that boring abdominal pain. She's nauseous. Her vital signs are stable. Her breath sounds are clear bilaterally. Her bowel sounds are hypoactive or very quiet. Her last bowel movement was 2 days ago. We should also assess her abdominal area for gray Turner sign and Cullen sign, which are bruise-like discolorations that can occur when the enzymes leak into the skin. So the doctors have diagnosed her with pancreatitis. The CT scan showed the inflammation that is characteristic of pancreatitis. The ultrasound showed gallstones, and these explain her symptoms. We also get some lab values back that confirm this diagnosis. Elevated amylase and lipase. The elevation of these two pancreatic enzymes signal injury to the pancreas. When the pancreas is damaged, it's not able to regulate glucose levels. There's a decrease in insulin secretion, so we may see hyperglycemia or elevated blood glucose. Miss Rhee has gallstones, and elevated bilirubin and ALT, the liver enzyme, are two indicators of obstruction in acute pancreatitis. White blood cell count is elevated due to inflammation, and the higher it is, the more severe the pancreatitis. And we already talked about why calcium levels would be low due to the lipolysis. Now the plan is to decrease her pain, improve her nutrition, maintain hydration, prevent complications, and we can achieve these things first by resting her pancreas. That is why we keep her NPO, or nothing by mouth. This will decrease enzyme production by the pancreas. The doctor will order IV fluids and IV electrolyte placements as needed, probably starting with calcium. We need to strictly monitor her eyes and nose. The doctor will also most likely order a proton pump inhibitor like Protonix to decrease stomach acid production, and an antiemetic for nausea. However, if she continues to vomit and we begin to hear absent bowel sounds, this signals ileus, or no peristalsis of the stomach. This happens in severe cases where pancreatic enzymes have leaked into the abdominal cavity. The doctor may order a nasogastric tube, NGT, to suction the stomach. The NGT will decompress her stomach and prevent gastric juices from stimulating the pancreas. We'll probably keep the NG tube in until the patient passes gas or has a bowel movement, which signals the return of peristalsis. We'll also give her scheduled pain medication for her pain so that we don't have to play catch up later, and slowly wean off the opioids as the pain resolves over a few days. We can also recommend that Miss Rhee lay on her side with her knees to her chest. We must check her vital signs frequently because substantial changes can indicate complications. So check for hypoxia, hypotension, and tachycardia. These are signs of shock and other complications I will talk about in the next slide. Now, Miss Rhee Turner will not be able to eat or drink for a few days. In severe cases, patients might require enteral feeding, which is liquid nutrition through an NJ tube, nasal jejunal tube, that goes through the nose to the jejunum. Once patients are allowed to eat, start them slow with low-fat, high-protein diet. No alcohol or caffeine. On evaluation, Miss Turner should have no pain and be able to eat without any nausea or vomiting. I want to mention something that you might see for patients with chronic pancreatitis, and that is steatorrhea, which is stool that smells worse than normal and is frothy looking in the toilet. And this occurs because there's a decrease in lipase production over time. And while there's no medications for acute pancreatitis other than pain medications, there is one called Creon, which is a pancreatic enzyme replacement therapy medication for patients with chronic pancreatitis and pancreatic cancer. These patients can't secrete digestive enzymes. This pill actually has amylase, lipase, and protease in it. Patients have to take this pill with meals and with a glass of water. It's a pretty large pill that can't be crushed or chewed, but you can empty capsules into applesauce. Now, here are the complications that can develop and some things that you want to watch for when a patient is admitted with pancreatitis. We already know about jaundice. Type 1 diabetes can occur if there's total destruction of the pancreas, and type 2 can occur because of decreased insulin secretion with all of the islet cells being destroyed. Left pleural effusions. or fluid in the pleural space that compresses on the lungs, is a very common complication because pancreatic fluid will actually leak out of the pancreas and into the pleural space by traveling through lymph channels. So you want to listen for diminished lung sounds here. We talked about ileus that requires an NG tube, acute respiratory distress syndrome or ARDS. It's not really understood exactly how this happens, but somehow fluid leaks into the alveolar spaces and the patient will experience shortness of breath and hypoxia, which is why you want to monitor the oxygen saturation frequently. You can imagine how hemorrhagic shock occurs due to the vasodilation and destruction of blood vessels we talked about, but basically a patient bleeds out into the abdominal cavity, which is why you need to be aware of sudden drops in blood pressure and tachycardia. Both ARDS and shock are deathly situations and require transfer to an ICU if the patient isn't already there. And that's all I have on pancreatitis. Please comment, like, and subscribe.